Thank you. So, this session is focused on MET, and the panelists, please join Dr. Mohit Sharma, Delhi, Dr. Pushpak from Mumbai, Jartin Sarin, Chandigarh, Dr. Nandini Menon, Mumbai, Dr. Bhavesh Poladia from Namakkal, and Dr. Rashmi Gudar from Karad. So, I really don't have too many slides, simply because the number of patients involved, which we are going to discuss in our individual experiences, is probably very small. I call it MET matters. What I would like to say is, okay. So my basic question to everybody is, does MET matter? One answer which I know is for individual patients and their carers, givers and families, yes. But as if you look at from the other perspective of clinicians treating 100 lung cancer patients, what is your real chance of encountering a MET alteration? And we can start from the extreme end. Give us your experience of how many patients with MET alterations have you seen, what type have you seen, how many you have treated?
So, since we have started doing the panel, we have started seeing different uncommon mutations which are beyond Alcross and EGFR. MET, a very small percentage, not very big percent, and we still don't have a very great opportunity to do it when the patient starts progressing. So once it is done, then patient usually is a little borderline, and then we cannot go ahead and take them in all of them. So I think personal experience is very low, the percentage is very, very low.
Dr. Nandini, you should have the largest experience, I believe, because being in TMH.
Yes, so now our incidence of detecting MET has gone up because we are using more and more NGS, which we were not doing before. But still, it's less than 5% of our patients.
So 5% of adenos?
So probably around 3 to 4% of adenos would be MET. But we are not able to offer all our patients the ideal MET inhibitors in most cases. A very small number which actually get the MET inhibitors.
Well, frankly speaking, I've seen just one patient, and that too was investigated by someone else. It was more of a sarcomatoid variety of tumor, and in that, actually, this particular thing really helped and changed overall prognosis of that particular patient. So yes, you're lying about for individual patient and caregiver family. It really matters.
Although it's rare, but unluckily I had 2 patients in just last 1 year, and both my patients couldn't afford any of these TKIs, but surely it's going to be important.
Yes. 2023, I have seen in my practice not just one patient. That was metabolic.
So, from what I'm hearing is, obviously it's not as common as we would expect it to, in order to have enough experience with treating such patients and have our own insights into the disease, right? So it's still something which is likely to get picked up more as and more NGS starts being done. The other question is obviously testing, right? So when, whom and how. So in the context of timing of testing from the time of diagnosis, when would you do it? Whom would you select for testing, which basically is going to be driven by histology, smoking status, the stage of the disease or the gender, and how would you test it? The method chosen or standalone versus multiplex? We can start from the other end this time, please.
I do NGS on patients of metastatic. If I come across a patient of metastatic CLR,
and after biopsy, as the report comes, whether it is adeno or squamous cell carcinoma, I order a NGS panel for that.
So all
Yes.
metastatic non-small cell lung cancer, irrespective of smoking status or even histology.
Yes.
Okay, and
Earlier I used to do EGFR, ALK, and ROS, in adeno and EGFR, and ALK only in squamous, but now I order NGS for all the patients.
Okay, and so that is you don't do any standalone testing for EGFR ALK, you just go straight away for an NGS. Okay, and so given the scenario that if there was a female never smoker adeno and you did a standalone test for EGFR ALK and it came positive, would you still need an NGS? I mean, that is the argument against doing NGS for everybody, given the resources and given also the tissue constraints. And NGS processing requires greater, not just time, it also requires greater expertise and it also requires greater tissue than doing an ALK IHC. So, if you have a patient enriched,
even if tissue is an issue, then in that case, sometimes we do only EGFR, ALK, or even very common mutations.
even if tissue is not an issue, an ALK IHC can have a turnaround time of 2 days, does not require a more advanced testing facility, and if you pick up a strongly positive IHC, you may or may not do an NGS, right?
Yeah, that's true. But given an option, if the patient has a good performance status, can wait for treatment, there are definitely clinical scenarios in our practice that the patient will not wait for treatment. In that case, definitely we go for specific IHC testings for these. But otherwise, in general context, I prefer if the patient can wait for treatment.
Right. Your thoughts?
Although it is advisable to go for IHC, NGS, everything together, but more practically we go for NGS.
So, there is always a difference between the ideal scenario and the practical setting. So, ideally, all patients should go for an NGS and that to a comprehensive one. But practically it doesn't matter, and tissue and issue really matters, and the clinical scenario really matters. So, yes. Obviously, if you and also it really matters that after doing NGS, whether that particular treatment is going to be affordable to that particular patient or not, that actually matters. So a lot of things, but in an ideal situation, and sometimes ideally it should go in the first line, but sometimes when you see the clinical scenario is different and all, you tend to do it in the second line, and the treatment might change in the second line, possibly.
Dr. Nandini, your comments last because you were at the largest center. I'll have his comments first.
So, in ideal world, we have to do NGS at all points, so starting from the diagnosis, and then every time when the recurrence happens or metastasis happens. And obviously now it is across all NSCLCs, and obviously NGS is the choice. But if we are doing it very selective, it has to be a shared decision rather than a personal decision, because it will have its legal implications. Whatever the histology or whatever the history is suggesting, we still can't pinpoint to one molecular marker. So it's very difficult to pinpoint at one molecular marker. It is at least has to be a short panel which will include most of the common genes.
So you said NGS at all time points. So let's assume that there is a scenario in which you are able to do an upfront liquid and tissue NGS at diagnosis, and you do not find any targetable oncogenic driver alteration. What is the probability of picking up anything at subsequent progression?
I think the next subsequent will be a full NGS rather than a fixed NGS, because obviously we are looking for something which is uncommon and not picked up in that 8, 12 or 15 gene panel. So if we have to do something, we have to go for a broader panel or a complete NGS.
No, the aim of any testing is that if you get something, you should be able to action upon it, right? So if you do a 50 gene panel at progression, and you find a TP53 at that, for which you are not able to do anything, then the argument against it is why do it at all?
Actually, we can prognosticate.
So I think what I would just answer in that way, that if TP50 is there, we know that it will overrule all other, even in the favorable molecular marker with TP53, we know that they are not the one who are going to do well. So if the patient understands that and both the parties are convinced, then we may not go for anything else. But otherwise, basically, when we see for molecular testing or NGS testing, we are expecting at least 60% or 70% patient should harbor some kind of mutation. So that is the reason why we don't want to miss that 10 out of 7 or 10 out of 6 are going to be having some kind of mutation. So we want to hunt and look for that, and maybe in some clinical trial we can put, even if the patient is not affording it, the medicine is not available in market.
Dr. Nandini, what happens at TMH is NGS after standard, or do you do NGS after standalone testing?
So 5 years or 6 years back when I was a resident, we used to do standalone tests for EGFR, ROS and MET. We had four things that we used to do. Now over the past 2 years, because we are getting more affordable NGS, a lot of NGOs are helping out. So we are slowly trying to offer NGS to all patients in the first line. But there is still a group of patients who can't afford the support. So in them we do EGFR, at least standalone testing, EGFR, ROS, MET, at least that basic thing is done. If they can't, that's a smaller number. Now we are, like previously it used to be 80-20 only would get NGS. Now we are slowly moving to like 50-60. We are trying to get an NGS, and maybe 20 to 30% we go for standalone testing because of practicality. At the recurrent setting, it's the same issue, sir. If we can get an NGS done and the patient is willing for agreeable to a biopsy, he can afford, then we do try to get. But at times we have patients who have never undergone testing and they come from outside and we don't have any molecular, then we try to push them for a repeat biopsy and an NGS, if not at least maybe limited panel testing or standalone at that point. So it all depends on our patient context because of the practical limitations.
So from what I understand is that MET testing, because the panel discussion on MET, is largely done as part of a multiplex NGS testing, and it would be very unusual to test MET alone as a standalone testing, right? Is that correct? I don't know if anybody else has any other experience of doing MET testing as a standalone testing. What do you say, Dr. Prabha, US, what would you be doing? Do you ever do MET testing as a standalone test?
Not typically, but in the past we've done MET findings and I see just looking for MET amplification. But nowadays we do all this next-gen sequencing as part of a larger gene plan.
Thank you. So the other thing about MET is that its association with smoking exposure is far more than what you would expect for EGFR, ROS1, and so it's a slightly different distribution of patients which you would get. Basically, if once you have ordered, what really is considered a targetable driver alteration in the MET? So are you looking for MET expression by IHC? Are you looking at gene amplification or increased copy number? Or are you looking only at the exon 14 skipping mutation as we know it? Because there's a whole spectrum of abnormalities which can be done, and you maybe in a scenario when you have not ordered the testing or testing has been done outside by another clinician, and the patient comes to you either for a second opinion or for treatment, and you have to see the MET results and decide whether that is a candidate for MET targeted therapy or not. So,
what in 10 copies?
Sorry?
What in 10 copies?
10 copies of what?
For amplification, particularly.
So, basically what you're talking is amplification, which is increased copy number, right? So, 10. Okay. And is this
not for skipping, only for amplification? Obviously not for skipping, only for amplification.
So would you offer the drug if that is present?
For the data, I should at least discuss with the patient that these are the treatment options available.
No, the two trials which we have seen, what has been their enrollment criteria for the capmatinib and tivotinib? Has it been amplification, or has it been only been exon 14 skipping mutation?
Trial primarily involved the skipping mutations.
Right, so we don't know whether they will work as well because a story similar to that happened in EGFR long time back. That EGFR earlier testing used to be by immunohistochemistry, then it moved to amplification, which is copy number gain, and then finally the discovery that the mutations are what matters and not really the amplification or the IHC. So this may or may not follow that. Basically, there are four major categories of MET alterations: mutation, amplification, overexpression, and fusion. So, from whatever we know from these trials, they have been largely using enrolling patients with the exon 14 skipping mutation. How exactly they work, I think we can have experience sharing if anybody has used in conditions other than the exon 14 skipping mutation. Anybody from the audience, anybody in the panel, have you used any of these drugs other than a exon 14 skipping mutation? Dr. Park, if you have any idea.
We have not used these drugs in amplification, but I've used crizotinib in amplification. And if you look at the original trials, they included patients with gene amplification geometry quantitative. And even though the response rates are lower than those with mutations, you still see about 20-25% response rate with capmatinib and tepotinib if your gene copy number is more than 10%. And that's about what you would see with chemotherapy anyway. So whether you use chemotherapy in those patients or whether you use a MET inhibitor depends on availability. But at least in our practice, if I saw someone with a gene copy number of greater than 10, I would consider using these MET inhibitors.
So one important question which also arises is, if you are looking at MET as a mechanism of resistance at progression with either EGFR targeted therapy or something, that would not be an exon 14 mutation, right? And that may or may not be. You could have just an amplification as the mechanism of resistance, in which case you could try drugs like crizotinib, which are, like in today's scenario, more affordable than the actual MET inhibitor. So again, Dr. Nandini, what has been your experience at TMH of MET amplification or MET alteration as a resistance mechanism and not as a de novo mutation?
So we are detecting, and it's not as common, many times we are not able to find, but I think maybe around 5 to 6% are presenting with MET amplifications post EGFR therapy. Not all of them we have targeted with MET inhibitors, few have received crizotinib, and most of them go on to receive chemotherapy.
So crizotinib really doesn't work great in that setting as well. I mean, that's my experience also. We had one EGFR positive patient on whom a MET amplification occurred at progression. We tried crizotinib 3 months or 4 months PFS and then had to go on to another line of therapy. So I think for interpretation of reports, it's very important to be able to distinguish these and not just see a MET report highlighted and then go on to these drugs. I'll take the opinion of the panel. This is a 56-year-old lady, homemaker, never smoker, no comorbid medical conditions, presented with chest pain and loss of weight. A CT scan showed a left lower lobe mass and a right upper lobe and left lung nodules, and ipsilateral and contralateral mediastinal and hilar lymph nodes, along with metastasis with cervical lymph nodes and bones. The biopsy was adenocarcinoma and SCLC, stage 4B, PS3, and palliative care was initiated. The patient was unfit for chemotherapy. We did an in-house testing, which was standalone testing for EGFR Al-Cross1, negative, PD-L1 TPS less than 1%, which is negative, and an NGS was done, and this is what was picked up on a liquid biopsy. NGS, the tissue had a QC failure and could not be processed. So if you are able to see, what do you find here? Anyone? So summarize it as an exon 2 mutation with a which has been classified here as a variant of unknown significance. The important thing is the variant allele fraction is 100%. What would that indicate?
I would say there is some mutation in the MET, but it's not targetable actually. So
It's something, there's something, another catch to that besides that it's not just, so I agree, it's not an exon 14 skipping mutation, it is not somebody whom you would offer the capmatinib or tepotinib, but there is something which should prompt precisely. So that VAF is very, very high, it is 100%. So it only means that one should consider that this may not be actually a somatic or an acquired genetic alteration, it may be a germline. Treatment point of wise, it doesn't make any difference, but it is as we order more and more NGS reports and as we have to end up interpreting them, we need to realize that we will also pick up germline alterations, which as time passes may also become actionable, and you may want to end up screening the family if you have, it changes the outlook.
So also check what is present, so might trigger.
Yes, so again, this does not change management, but it is something which one has to get familiar with interpreting. This is another patient, 56-year-old lady, homemaker, never smoker, lung adenocarcinoma, and the NGS showed this.
Exon 14 skip.
Yes, that's at the top, and that has a VAF of 52%. What else?
There's a second, there are two MET mutations, one which is a US also there, so we don't know what exactly that impacts.
Right. And there's a coexistent TP53, again something which we find very commonly in NGS reports, and in a way portends poor prognosis. So again, whether one would offer this patient directly MET targeted drug or proceed with chemo first and reserve the MET targeted therapy for later on is something which can be subjected to discussion and debate, because when you do more and more NGS, you are more likely to find coexisting mutations, some of which may be prognostic, some of which may be just bystander, and then the treatment decisions are going to be based on not just the mutation which you are looking for, the driver alteration, but also what is there to influence it. And for example, we know that if it is EGFR and you have coexistent RP1, they are more likely to have a small cell transformation and more likely to have poor prognosis with EGFR TKI immunotherapy. So this is things which we learn with time. This we have again largely discussed: what drug to use, what line of treatment, what is the expectation of response, and what to do at the time of disease progression, because I think the abstracts were at progression on use of capmatinib and tepotinib. Now our experience from what I gather is still very limited, both in terms of the number of patients which we have seen, and even less with people who have gone on to these drugs. So when we are offering these drugs to a patient who is a candidate, we know these are very expensive right now. So how do we counsel them? Would you offer them upfront, or would you tell them that okay, we are going to use this drug later on? What is the expectation of a response?
Based on whatever data we have from the vision and geometry, the objective response rates were far higher in the upfront setting, around 46 to 51%. And the abstract which was not presented, that was the sequencing from the vision that showed in people who failed second line, it was around 29-22%. So if the patient had no other adverse prognostic mutations and it was a clear-cut exon 14, I would probably offer it upfront rather than second line. But if they did not get it, then maybe second or third.
Yes, if there are no issues with finances, I think, and it's just that MET exon 14 mutation which is standing out, then they should be offered this therapy at this thing. So, Ullas was here, I don't know where he's gone. Anybody else? Randeep, do you have any experience?
Yes, I have two METs. One was genetic polymorphism with a VAF of 60%. That was a mutation. The lab reported it as activating mutation. They told me to use capmatinib. I got back to them and what Navneet was emphasizing. And after discussion, they realized the VAF was coming 45%. Even in this patient also, I would suggest that we shall look upon other family members since the VAF is 52%. I have another patient who is just now on capmatinib or is on tepotinib. Admitted in the ward. He was started on paclitaxel carboplatin because he was having breathless. He was symptomatic, and then the NGS showed exon 14 skipping. 45 days has gone by, he's still pouring out. I discussed this case with Akhil also, he's still pouring 1.5 liters of, he has undergone a fluorous catheter. 40th day of capmatin has now started bevacizumab. I'm not, these are my two patients who I had experienced in the last 6-8 months.
Yeah, thank you. But I think still we are very much in the learning phase. I guess we would expect TMH to come up with some kind of data soon and enlighten us about how things are happening and what we are listening. So I really don't have anything more to discuss beyond that, but we are open. Yeah.
Another point actually Chetna also mentioned is that when I started this patient on tepotinib, there is a lot of edema and this patient developed pericardial effusion. The patient got admitted under cardiac as usual in a multi-speciality hospital. They underwent a pericardiocentesis. The fluid was sent for cytology. It was labeled as positive, and then IHC and cell block was sent, and then it came out negative. It was basically a tepotinib-induced edema. There was a lot of edema and effusions. This patient is now, after all that thing happened, he's come back. I put him on albumin and diuretic, and diuretic him. His effusion has come back negative. After this happened 4 weeks before. Now the check echo is negative. He's not having any malignant pericardial effusion. So we all, when you deal with lung, these things also become important, especially in my patient where already he is having a malignant pleural effusion.
Yeah, so that so MET targeting comes with this potential side effect of edema, fluid retention. In fact, we see that with crizotinib because crizotinib also has some amount of MET activity, so it's not uncommon for patients to present with swelling of the feet, and obviously these are drugs which are pure MET targeted agents, and you would expect hypoalbuminemia and peripheral edema to be much more severe. So I think we can wind up 2.5 minutes early. If there are any specific comments from anybody, or else I'd like to thank everybody for their presence. Okay, thank you so much.